So my name is Virna, and we are going to spend the next hour or so talking about suicide safer care, very particular to primary care practices and what we can do in primary care. And so this initiative is part of a larger initiative, as Scott mentioned, training primary care providers and their teams around the country. Which I have to say, of all the projects I've had the privilege to do in my career, has been the most fun to be able to go around and talk to primary care providers and teams like all of you. So we're going to be talking very specifically about primary care, what can happen in primary care. I would love for you to put any questions in the chat. I'll be sort of watching that as I go along, but really glad to have some discussion. So when we think about primary care, this, as Scott said, most of the primary care providers of all disciplines said, yes, I think suicide prevention is part of my role. Most people were not trained either in their current positions or organizations or in their training. And interestingly enough, 44% of the behavioral health providers in primary care said, I am not comfortable or competent in really feeling like I know what to do with someone who is at risk for suicide. And so certainly wanting to try to do some different things around training and making sure that people have the information they need. So, and also to really make sure that we're thinking about suicide, one of the things that has arisen is just the risk of people in healthcare. We lose a physician a day to suicide in the United States. And so really, getting to pay attention to suicide, think about suicide in our healthcare settings. And certainly when we think about why primary care is so important in this effort, most people in suicide prevention will say, like, we've got to really try to engage primary care practices so that we can really move the needle in suicide prevention. So we know that many of the people who die by suicide saw their primary care provider in the month of death. One of the things we also know is that when they looked at patients who resurfaced in care, so they were not seeing dental, mental health, primary care, they were disengaged from care, they actually resurfaced an average of 2 times during their month of death in primary care. And so I think that's an incredibly interesting piece because it tells us that we have a real opportunity to engage people. And if you have any regulatory bodies, if you're so lucky as to have Joint Commission or CARF or one of the others, they are saying, listen, you really have to think about how you care for your patients at risk for suicide. You have to be thoughtful about having a pathway, having some systems in place like you do for other chronic illnesses like your diabetics or your asthmatics. This is a really famous zero suicide slide with the Swiss cheese. And one of the things that is really helpful for you to think about is, where are people falling through the cracks? Where are they falling through the holes? So as an example, we had a young woman died by suicide, and she had called and canceled a WIC appointment, a primary care appointment, a behavioral health appointment, and no one that picked up the phone knew that she was at risk for suicide. So they didn't know to do anything different. And there was no system in place to know that she had canceled 3 appointments and had been flagged as suicide risk. And so really thinking about places in your practices where patients could fall through the cracks. Most importantly, the front desk. Oftentimes we don't share clinical information, or clinical information isn't available to our people at the front desk. But if we want them to do something different when someone at risk for suicide calls to cancel an appointment, then that's information that they might need to have. So really to start to think about some of that, and really making sure that you're sharing it with everyone on the care team, and really engaging everyone who might be at risk. So really making sure that you've done things to be able to close all of the cracks and make sure that you're not having any difficulty with people falling through the cracks in your practices. And so one of the things that we really want to try to do over the course of the day is make sure that we're sharing information with everyone on your care team and making sure that we're engaging everyone who's caring for patients that are actually thinking about suicide or are at risk, and really incorporating all of the pieces of zero suicide, which I know you've talked a lot about and will continue to talk about. So I know that many of you might be familiar with the Zero Suicide website. I encourage you to go there. It has lots of information and training, and you can get some really nice CEUs and CMEs there. So one of the things that we've heard as we go around is mostly we hear from providers, I don't know what to do, right? I don't have the information. I've never been trained. I'm not really sure what to do when someone tells me they're thinking about suicide. And one of the things that I always say to people is, there's one thing that is really the most helpful for people. Anyone can do it, regardless of your background, your discipline, how long you've been in the practice, and that's to give someone hope. And we can all give someone hope. And so if we all think about a time in our lives when we told someone something that we weren't sure about, maybe it's something that we've told for the first time we've ever said out loud. And that first couple of seconds, that first initial response from someone really helped us decide, did we regret saying anything? Were we comfortable? Were we going to continue talking? Would we ever talk about this again? And so thinking about, if someone's telling you they're thinking about suicide, it could very well be the first time that they've talked about suicide or ever told anyone that they were thinking about suicide. And so we want to make sure that our initial response is something that is going to be incredibly helpful for people, but also make sure that they know that this is a safe place. And so oftentimes I do what I call storage statements. So storage statements came out of a time when I used to train behavioral health providers to do therapy. And sometimes when they were in training, they'd get a little discombobulated, and we would come up with storage statements or things that they might be able to say that would be good in situations and help them get a little bit back on track. And so we've kind of transitioned, and we use this in suicide safer care. And so the idea is to think about 2 or 3 sentences that you would say to someone who just told you that they were thinking about suicide, maybe for the first time. And I had a primary care provider in the Midwest say to me, you know, Virna, when you were talking about storage statements, I kind of didn't really pay attention. And, you know, a couple of days later in my practice, someone came in, I was talking to them, and they said, you know, I knew this was going to happen, that you were going to talk to me about this. I had a rope this morning. I should have just hung myself. And she said, you know, I was really glad that I remembered your storage statements. And she made me promise to tell that story so that people would take time, maybe when you're brushing your teeth tonight, to think about some things that you might say to someone who just told you that they're thinking about suicide. And so as an example, what do we want someone to know? And people can feel free to throw some things in the chat. So first of all, what do we want someone to know? I want someone to know that I heard you. Thank you for telling me you're thinking about suicide. We want someone to know that they're important, that their life matters. Thank you for telling me you're thinking about suicide. You're really important to us here at the center. Your life is really important to me. Your life matters to me. Your life matters to us. And then we want to give someone hope. I have hope for you. I can see how strong you are. It took a lot of courage to talk to me about your thoughts of suicide. And so really thinking about those 2 or 3 sentences, you know, tonight when you're brushing your teeth, that you can say to someone who might have just told you for the first time that they're thinking about suicide. Also, one of the things we heard a lot from primary care providers and teams was, we don't have time. I get maybe 15 minutes with patients. I'm back to back. I don't have one single minute to spare. And having worked in primary care, you know, my entire career, it is so true. And so when we think about caring for people at risk for suicide, then we really want to start to think about having some of the same systems in place that we do for other chronic illnesses. And so I often tell a story, and now my husband knows I tell it, so we're good. And actually, for the mental health conference that Scott referenced, he didn't know at that time, but now he does. And so we went to the primary care provider with my husband. He actually was struck by lightning, true story, lost a lot of his hearing, brought him into the primary care provider, and lovely medical assistant took his height, took his weight, took his, temperature, took his blood pressure, and kind of left the room. And I thought to myself, well, that was a little odd, but okay. And 2 or 3 minutes later, the primary care provider came in and she took his blood pressure, and I'm watching, and I had promised to be an observer in the car on the way there, so I didn't say anything. And she said, listen, I'm really concerned about you. Your pressure is incredibly high. I'm not sure you're going to be able to go home. She asked him some questions, asked him about medication, got a little bit of information, and said, hey, listen, I'm going to go finish up with my other patients, and then I'm going to come back, and we're going to, I'm going to ask you some more questions, and we're going to figure out what to do. And that's what happened. We never talked about his hearing loss again during that visit because it was no longer front and center. And we all know that that happens in primary care every day, all day. It would be a beautiful day in primary care if people came in for just one thing, or they came in for what turned out to be the most important or life-threatening thing. And so, turns out never talked about his hearing loss, right? And so whether he had said, yes to suicide or his pressure was off the charts, we do the same things. We stop, we get information, we ask some questions, and we figure out an alternate level of care if we need one, or an appropriate level of care. And so very much the same thing for somebody who is at risk for suicide. And I think that's the way to start to think about patients who are at risk for suicide. We don't want to panic. We want to be able to use our storage statements. Thank you for telling me you're thinking about suicide. And we want to make sure that we're using appropriate language. So you're going to hear me talk through this presentation and talk about dying by suicide. We really want to make sure that we're not using terms like committed suicide, because one of the things we know is people commit crimes, right? They die by suicide. That we want to stay away from terms like successful or unsuccessful attempt. I was in an emergency room one time, and I was in New York, and I was introduced to a 13-year-old who had tried to die by suicide. And they said, here's so-and-so, she had an unsuccessful attempt this morning. So what message are we sending to that adolescent? We're saying you can't even die by suicide successfully, or had you been successful, you wouldn't be with us. So we want to stay away from those terms. We also want to stay away from terms like manipulative or attention seeking. I know there's some folks on the webinar that know me, and so they know I'm always getting into trouble, and I'm always having to say, that wasn't my intent. And so I don't pretend to know someone else's intent. What I do know is that if someone is talking to me about suicide, they are more likely to die by suicide. So I just stop there. It's way more helpful for our team members to know what someone actually said or did, as opposed to labeling someone attention seeking or being manipulative. So the other piece is, we know many of you are screening for depression, and that's incredibly helpful. We're going to talk a little bit more about that. But we also know that many patients who die by suicide don't have a depression diagnosis. We know that alcohol and substance abuse play a huge role. We know that social determinants play a role. So we had a primary care provider actually in Amsterdam, New York, when I was doing a training, and she stood up at the end and she said, I had this guy, one of my patients, and he died by suicide last week. And he had lots of medical stuff going on, and I was worried about him, and my team was worried about him. And, I saw him, my team saw him, and we never asked him about suicide. But when I'm thinking back, he had multiple health problems. He wasn't able to work as much. They started to have financial problems. They were maybe going to lose the home. His marriage was under a lot of stress. He had started to drink a little bit more than he should. And so she was like, he was absolutely at risk for suicide. And so really starting to understand the role that social determinants play in suicide. Also transitions. Transitions are a huge risk for suicide. And this is coming out of a medical or mental health hospitalization, incarceration, substance abuse treatment, foster care, physical rehab. Those are all times of incredible risk for patients. And many healthcare organizations are actually asking people directly about suicide during those times of transitions. I would also really encourage you to start to think about how you know how many patients are in your practice who are at risk for suicide. As I go around the country, I often ask primary care providers, healthcare organizations, tell me about your diabetics. How many diabetics do you have? And everyone is so proud to tell me how many diabetics and a registry that they might have built and their A1Cs and what they're doing around diabetes care. And then I'll ask, well, how many patients do you have at risk for suicide? Crickets. And so really starting to think about how you can know how many people are at risk in your practice. One of the best ways to do this is using the ICD-10 codes. They're already in your electronic health record. We fortunately live in a world where there is a code for everything, right? I'm in South Carolina right now. If I walk outside and a bat falls on my head, my water skis catch on fire, we have codes for that. There are codes for suicide risk. They are in your EMRs. You should absolutely put suicide on your problem list. And what that does is it gives you structured data to monitor your population. It helps the rest of your team know, and that's helpful to care for someone at risk. Someone might make different decisions if they see that someone is at risk for suicide. And oftentimes people will say to me, well, I'm not sure that my patients are going to like having suicide risk on their problem list. And I will say, well, I've never had anyone say that they didn't. But what I tell people is, I'm really glad you talked to me about your thoughts of suicide today, and you really matter to me. And I want to make sure that every time I talk to you, my team talks to you, we see you, my team sees you, I see you, that we make sure you're safe. And so I've put that we've talked about your thoughts of suicide in your chart so that we can make sure that you're safe. And really having those conversations with people. I would also say, think about two different populations. We oftentimes pay lots of attention to newly identified people, people that just said yes to suicide, and what happens then. But the reality is I'm going to come back to you for primary care. So you have systems in place that you ask for other chronic illnesses. I have diabetes. When I go to the primary care doctor, they ask me questions. Some I like more than others, but they always ask, right? They always check my sugar. They always ask questions. And so what are those processes like for your people at risk for suicide? There was an adolescent in a school-based health center in New York. He was identified, answered yes to question 9 on the PHQ. Lots of commotion, was referred out for treatment. He came back 3 weeks later for a follow-up visit to get the same forms filled out that he had come in for the first time. He was seen, got the forms filled out, and left. It wasn't on his problem list. He had seen a different provider. No one asked him about suicide. No one asked him if he was safe, and no one asked him if he was engaged in care. And so really thinking about what is the expectation for a follow-up visit in your practice, because even if I'm in the best behavioral health care in the world, you want to make sure I'm safe on the day that you're seeing me, and you want to make sure that I'm continually engaged in care and have some follow-up. So many of you are using the PHQ-9, whether you use it in person or whether you use it on the computer. It's really helpful. And what I will do is I will take the PHQ either, again, on the computer or in front of me, and I will go through it and I will say, I see that you're having trouble falling asleep and staying asleep. And that's a problem for you more than half of the days. And I see that you're having trouble concentrating on things, like the newspaper or TV, and that's a problem for you, several days. And so those are probably connected, and it's really important that we figure out how to get you sleeping a little bit better. I also see that you have thoughts that you would be better off dead or hurting yourself in some way, and that's a problem for you more than half of the days. So I'd like to start there. So thank you for telling me that you're thinking about suicide. You're really important to us here, and we want to make sure that you're safe. And so that we're going right from the PHQ into our storage statements and then into asking some additional questions. And so really thinking about what that flow looks like in primary care. Many of practices didn't know that there was a PHQA for adolescents. And so I put a copy of the PHQA here. I also put, which many practices are doing, particularly for adolescents, because one of the things we know is there is an incredible increase in the number of suicides in 10 to 14-year-olds, and they are very lethal attempts. They are hanging, they are jumping off buildings in that order. It is incredibly sad to me how many times a week I use pediatric and suicide in the same sentences. What NIMH is suggesting is that ages 10 and up, you actually do screen for suicide, and ages 6 to 9, if it comes up, if you have a reason to ask if they're brought in for suicidal thoughts, then you would use the screening on the bottom, which is actually called the ASQ. The ASQ is more validated for children and adolescents, so most practices in emergency rooms will use it. There is a wonderful toolkit on the NIMH website with information on the ASQ. It also has a really nice script for nursing staff and also for parents or guardians. That's a lot of reasons why primary care practices, pediatric practices, will use the ASQ. And certainly incredibly helpful. But if you think that your adolescents don't know about suicide, they know someone who has died by suicide, they know Robin Williams, they know Kate Spade, they know those folks, who have died by suicide. And so certainly having a conversation about suicide is going to be incredibly helpful for that population. It's also going to be incredibly helpful to think about alternate levels of care and appropriate levels of care. So we know that sending someone who's thinking about suicide to the emergency room every time is actually not only not helpful, but in many cases dangerous and makes things worse. So just like any other chronic illness, we want to make sure that we're having an appropriate level of care. If I have asthma and I go to the primary care practice and I get sent to the emergency room every time instead of getting a treatment, right? What's going to happen is I'm eventually going to say, you know what, I'll just go right to the emergency room. Or, you know what, I don't want to go to the emergency room. I don't need to go to the emergency room. So I'm just going to stay home. And then we have people with asthma and suicide risks staying home, which we don't want. And so really thinking about appropriate levels of care. There is no magic in the emergency room. I worked for 17 years in the Putnam Hospital emergency room in New York State, in Carmel, New York, for anyone who knows where that is outside of Mahopac. And there is no magic that happens there. And most people I actually did not admit because that was not the level of care that they needed. And so we really want to think about assessing risk, which can and does happen every single day in primary care settings and can happen for suicide, just like it does for other chronic illnesses. And so when we think about assessing for risk, this is actually the Columbia scale, or affectionately known as the CSSRS. This is affectionately known as the primary care version. And so one of the nice things about the CSSRS is it is evidence-based. So you always want to make sure you're using an evidence-based tool, whether it's the ASQ that I just shared or the Columbia scale. So most practices will use the Columbia scale for adults. What is super nice about this is that there is very clear things that you can do for your yellow and orange patients. Those patients who don't have intent, One of the big risk differentiators is intent. I can think about suicide. Many people think about suicide. In fact, some outrageous number, like 66% of our high school students have thought about suicide. And actually just under 9% of them have attempted suicide. And so those numbers are staggering, but certainly lots of people think about suicide. Lots of people know how they would die by suicide. I talked to a gentleman one time that I often talk about, and he was in Poughkeepsie, New York. And if any of you have been to Poughkeepsie, there's like nothing to do in Poughkeepsie except a walkway over the Hudson. And so he was identified by the PHQ-9, and he said, yeah, I think about suicide. And he said, yeah, I actually would jump off the walkway. And he said, and I wouldn't jump where, you know, there was the fence, they put up the fence, but I also don't want to land on Route 9 or the railroad tracks. Like, he had really thought about, you know, where he would die. And I said, well, do you intend to die, you know, by jumping off the Mid-Hudson Bridge today? And he said, absolutely not. And so we certainly talked a little bit more, but that intent, right? So have you started to work out or worked out the details of how to kill yourself? Do you intend to carry out this plan? Have you had these thoughts and had some intention of acting on them, as opposed to, I have the thoughts, but I will definitely not do anything about them? So the patients who are yellow and orange are markedly differentiated from those patients in red, right? The people that have intent, those are the folks that need another set of eyes, might need an alternate level of care, need someone who can do an assessment for them and figure out what the best course of action is. And one of the things that we really want to talk to people about also are protective factors, right? So the more protective factors I have, or reasons for living, and the less intent, the less risk I am. The more intent I have and the less protective factors, the less reasons to live, the more at risk I am. I always think about it a little bit like a seesaw. So kids, right? And I always reinforce, yes, absolutely, your children need their father. Pets, absolutely. It would be very difficult for your dog in the shelter because many pit bulls don't get adopted, right? Religion or job. I hear job from a lot of healthcare workers. So really talking to people about their protective factors and really making sure that we're doing something around safety planning. So safety planning is something that is very helpful to people. We used to do something around contracting for safety. We don't do that anymore because we know it's dangerous. So one of the things we want is, what's the minimum to do? So you have a yellow or orange patient, what's the minimum to do? So first of all, the suicide prevention line has been shown to save lives. It has been shown to be better than mental health treatment in some cases. And so what we want to try to do is give people the information to the Lifeline. I have them pull out their phones. And if you don't have the Lifeline in your phone, pull it out now, put that number in your phone. You may need it, someone you know may need it, a patient may need it, and this way you have it. I have them pull out their phone and I have them put the number in there. And then I say, listen, I'm going to go see another patient. Why don't you give them a call? Send them a text. That way they have an evidence-based practice accessible to them right on their phone 24 hours a day. I don't give people the cards, not that I don't like little cards, but I know I'm a reasonably competent person. And if you gave me a little card and then asked me where it was the next day, you probably have like a 50% chance of me knowing where it is. So put it right in the phone. Also, give them the information for Now Matters Now. So the Now Matters Now website is evidence-based. It's been shown to reduce suicidal thoughts and behaviors. It's really nice because it has some activities people can do. And so if you give them the Now Matters Now website, they can look at it on an office computer, on their phone, then they are now have access to 2 evidence-based practices available to them 24 hours a day. That is incredibly helpful for those yellow and orange patients in the Columbia scale. And so then you can also do, oops, is going to be a long day, isn't it? So then what you can actually do is talk to people about how to get on the Now Matters Now website, how to be able to do some of those things, and then give them information on suicide is different. If they have a caregiver with them, a parent or a guardian, the Suicide is Different website is incredibly helpful for people. We also want to talk a little bit about safety planning. So one of the things we know about risk is that it can change. I could not be at risk this morning, but be at incredible risk this afternoon. And so what we want to try to do is give people some things that they can do. So if they're at risk, the most risk they could be, they have some resources at their hands. I actually give this or do this with everybody. And one of the things I say is, you know, when we were young, we were taught if we caught on physical fire to stop, drop, and roll. I have never been anywhere in the 29 states we've done this in where I've asked that question and people didn't know stop, drop, and roll. Like whoever taught us that, I don't remember the day I learned it, but everybody knows it. So whatever the system in place is, people did a really good job. However, the likelihood that we're going to catch on physical fire is not very high, but we all know what to do. So I want you to know what to do in case you catch on emotional fire, even though the likelihood that you're going to catch on emotional fire might not be that high. And so some of the same things work. You can stop, drop, and roll, because if someone stops, drops, and rolls, what are they not doing? They're not dying by suicide. They can splash cold water on themselves, on their face, on their wrists. They could take a cold shower, not making any decisions, make eye contact with someone, whether it's on the phone or whether it's in person, some very basic things. These are on the Now Matters Now website. There's a little flyer you can give to patients. I actually share it with patients, and I think it's incredibly helpful. Then there's also the ability to do some additional safety planning. And safety planning has some core components that we can do for patients who are in our care. One of the things we can do is get information on someone that we can call or that the patient can call if they're feeling in crisis. We can also get information and give them information for what to do, things that are helpful for them, right? Things that are distractions. One of the tips that I always tell people when you're getting a list with people, right? It has to come from them. It has to be personal, right? Can that activity happen at all times of the day or all times of the year? So in other words, I know I've done a lot of work in Montana and Wyoming. You can't really go at 2 o'clock in the morning in January in a lot of places. It's not safe to walk. So like, what can you do? I could go on the Now Matters Now website. I could call the Lifeline, right? That we're calling people that you list. If I list Scott on my safety plan, then we want to give Scott a call and say, Scott, you're listed on Virna's safety plan in case she's thinking about suicide. And Scott can say, yeah, that's cool, but it's a little scary for me. So we could give him the Suicide is Different website. We could talk a little bit. Or maybe Scott says, that's great, but I'm really busy during the day and I can't pick up my phone at work. Or sometimes I don't have service at home or at the end of the month. And we can say, if Scott doesn't pick up, it doesn't mean he doesn't care. It means that he's not able to answer the phone. And so maybe we call the Lifeline instead, right? Or maybe Scott says, listen, I only met Virna once at this conference. I didn't really like her that much. No, right? And then, so then what we could do is we just pick somebody else. That's okay, right? It can change. Why do you think Walmart's on a lot of safety plans? It's accessible by public transportation. It's open 24 hours a day. And I ask people, how can we keep you safe today? They've thought about it and they have lots of good ideas about how to stay safe. It's important to know about lethal means and lethal means restriction. One of the things we know about lethal means is that if I can keep someone safe and they don't have access to their gun, then they're not likely to switch means. I personally think it's because it gives people hope. We want to make sure that we talk to everyone about lethal means, and we want to make sure that we let them know that it's temporary. So we've taken some steps today to make sure that you don't have access to your gun. This doesn't mean that you're never going to be able to have your gun again, or you're not going to be able to go hunting in the fall. All of my patients that talk to me about suicide, who talk about using their medications, there's a lot of steps we can take to make sure that we're keeping them safe. We can try to have the pharmacy give you individual pill packs, because we know that having to open each individual pack actually helps save lives. And so it's really important to know what someone's method is, and then be able to talk to them about it. And also, don't assume that the medication you're giving them is the medication that they would use to die by suicide. I say, you've talked to me about your thoughts of dying by suicide and using medication. Where do you have access to medication? And so I had a situation recently where someone that works for my organization actually helped a patient with their prescription medication and engaged their mom, but they lived a block away from a pharmacy and had access to over-the-counter medication. And oftentimes when I ask people, where would you get the medication? They say, well, when my grandmother died, my aunt kept all of her medications, right? And so she's got bags of them and she lives down the street. And so really trying to figure out, okay, what are some of the things that we can do to keep people safe? Where do you have access to a gun? Where would you get that gun? And where do you have access to a gun? What gun would you use? Do you have access to any other guns? And starting to think about some of those resources or some of those things to do is now to talk to the pharmacy about the individual packs. I like the Amazon pill pack because they come in a box. They're individually wrapped. It's really incredibly helpful for people. And so we also want to think about what are we doing for patients who we've identified? How can we support them? Again, one of the things that we really want to do is give people hope. Hope, again, saves lives. And so caring contacts are something that have no ask to them. They're just something that says, hey, I care about you. I'm thinking about you. They're evidence informed. What many practices will do, will send a note that day to someone that they've identified at risk for suicide. Really glad we had a chance to see you today. I'm looking forward to seeing you next week and signing it, or having the provider sign it. That is incredibly helpful for people. It came out of Australia, where they would send people into the outback after a hospitalization. They weren't going to see them again. And what happened is that it gave people hope, and they saw the suicides get reduced. So I know for me, just to give you an example, when I worked in the emergency room, when I sent someone home, I would actually write them a little note. Hey, really glad we had a chance to meet. Hope this note finds you well, Virna, and I would send it off. And I worked in a community where the likelihood, that you were going to find, run into someone that you cared for was pretty high. And so I was in the grocery store. This woman came up to me. She pulled my note out of her purse and she said, Virna, I carry this with me. It's helpful. And so just knowing that somebody cared out there gave her hope. And so what I don't want you to do is underestimate the value of the storage statements, the value of being able to give someone hope through means restriction and safety planning. And also to really think about managing your patients at risk for suicide like other chronic illnesses. So if I'm having asthma and I come into your practice, what do? You might give me a treatment. You would ask me questions about my medication and my history. You would ask me about environmental triggers. You would ask me about emotional triggers. You might give me some education around how to use a rescue inhaler or a spacer. You might make a referral for someone to come out to my home, or for a pulmonologist. You might do an asthma action plan. And so when you think about all of those steps and all of those things that you would do, you do that routinely for lots of chronic illnesses. So all of that would be incredibly applicable to someone who was at risk for suicide. We stop, we get some information, we use our storage statements, we assess for risk with the ASQ or the Columbia scale, we figure out an appropriate level of care, we do some safety planning and give some evidence-based information. And that can be incredibly helpful for your patients. So we have about 5 minutes left. I wanted to stop there, and I can answer any questions in the chat or any comments that you might have. Okay, so reassessment of risk for orange or red. So one of the things that I think it's incredibly helpful to do is to probably bring those people back, you know, every week or every other week, so that they're coming in, you're checking on them, and you're doing either the Columbia scale or the ASQ each time. Most practices now will do that as sort of a standard of care. To be able to ask the 6 questions from the Columbia scale or the 5 questions, you know, from the ASQ when people come back for those follow-up visits.
Virna, I have a similar question. If we were to incorporate something like a suicide alert in the chart, how often do you reevaluate when to change the alert, or what metrics do you use, or do you keep it on there forever under the premise that it's a, you know, an important thing not to miss?
You know, you're not even a plant. That's a beautiful question. Thank you. So a couple of things, you know, one of the things to think about, and it's, you know, you hear in the zero suicide work, a care pathway, right? So one of the things that I really like about putting suicide on the problem list is that you can resolve it. And it stays there in the history, and it's helpful to put the means there, because someone at risk is always going to be at risk for the rest of their lives, but they might not be at acute risk. So generally, I don't recommend taking someone off of the pathway or active problem list that's had any kind of a transition in the last 30 days, has any kind of a psychotic disorder, or anyone who's had a med change. That actually is incredibly important to be able to do. So, you know, those folks are kind of a no-go. We don't take them off for the 30 days. But after that, if someone has said no to intent on the Columbia scale, as an example, for 3 months, then most people would move them to historical. And then you would ask them, you know, at each visit, the Columbia scale or the ASQ. So one of the things about, you know, having an alert, it's really important to talk to people about the alerts for suicide safer care and really compare the alerts to what you have for other patients, right? That if someone, you know, has a particularly bad allergy or some other, you know, really important consideration, then we flag it because it's part of patient care. And so to say to our teams, listen, many people in our community are dying from suicide, and we're going to really do our part to make sure people are safe. And so one of the things we're going to do is ask when people come in, and we're going to note it in the chart to be able to do it. But one of the things that I would say is, in a prior life, I had the experience, it's one of those times when you thought you were brilliant and you weren't, is I made the electronic health record red if someone was flagged, you know, with suicide on the problem list. And it turned out that providers didn't do anything different, because we didn't talk to them about what the expectation was and about doing the Columbia scale and training them about how actually quick it can be, you know, when you're checking in with someone. So certainly some things to think about. So there's a question in here also about contracting for safety. So the idea that we're going to have someone promise not to die by suicide is really more about us than it is about them. And so what we really want to do is we want to make sure that someone's safe and someone has some tools, right, that they can use to be able to stay safe. and it has to be very personalized, and it has to be something that's going to be helpful for them. It's just when we think about goals for other chronic illnesses, right? If you tell someone, well, you know, you really have a high BMI and your A1C is really high, I want you to sign this document that you're not going to eat bad. And that's it. And like, that's not helpful, right? And so what we want to try to do is say, well, what do you think would be helpful for you? You know, well, I'd like to stop drinking soda. Well, what could you do today around not drinking soda, right? So that you're really working with someone about things that are helpful for them.
I wanted to piggyback on that and then ask a clarifying question. So, I mean, just to differentiate, contracting for safety is different than safety planning. Contracting for safety, right, as most of us know, is like, I agree, I will not kill myself.
Yes.
And that is like, is a, you know, as we call it, like a CYA statement that we stopped doing a while ago. But the safety plan, and I feel like I heard you say this, but I want to clarify, was say, I'm a BHC, by the way. I know we've met before because I work for CMA. So the safety plan, oftentimes in BHC worm handoffs, we don't have the time to do the safety plan in the visit if the patient won't make the time, you know, won't allow us to make the time. But I feel like what I heard you say was, here are some of these things that can be useful in the moment. And then is that adequate? And then schedule the follow-up visit to do the safety plan. Would that be recommended? Would that be okay?
I don't know if I would recommend it, because you know, you want to be able to give people something that's helpful for them. But I think I would also like to take a moment and say, listen, you're really important to me. What is something you might be able to do today to help keep you safe, right? So that you can then really come up with some very specific activity, a very specific support, you know, and some means restriction, because that's going to be the most important pieces in that moment.
So that's if somebody is at like a level that is, you know, would they have intent and plan as opposed to somebody that's having ideation only.
Yeah, and then to go through, what I will do is actually let them, you know, do the Now Matters Now, like in an office computer, and, you know, have them call the lifeline right then and there before they go, and then come back to them so that they have that experience. Those are all really good things to do.
Thank you.
There's one more question here about liability sent to me. One of the best things that you can do is follow the same process every time and use evidence-based practices, using the ASQ, the Columbia scale, using the safety planning, making sure that you have a process in place. That's actually going to be the best thing you can do, just like with any other illness, but certainly with suicide risk. So I know we are at time. I know that my contact information is here. It was also in the chat. I really appreciate all the conversations and questions.